Hello everyone, this is Dr. Shikha. I'm a pediatric dentist. Today I'll be taking a short class on management of avulsed tooth. So avulsion is basically X-articulation of the tooth, that is when the tooth comes out of the socket completely. This injury is called avulsion. It falls under Ellie's class 5 classification of fractures. It's a complex injury that affects multiple tissue compartments, so not just the tooth, but the periodontal ligament, and sometimes the alveolar socket is also affected, so it might, hamper other tissues as well. It accounts for 1 to 6% of all the traumatic injuries which occur in the permanent dentition. The most commonly affected teeth obviously are the maxillary incisors, and the age group in which it usually occurs is 8 to 12 years of age. Reason being, the periodontal ligament is loosely structured and offers very less resistance to extrusive forces. So I'll focus on the management part of the avulsed teeth. See, it depends largely on the extraoral time. That is the time which has elapsed from the time of injury to the time it is replanted into the socket, and also on the type of storage medium. So in the emergency visit, the emphasis is placed on preservation and healing of the attachment apparatus, that is the periodontal ligament. And in the second visit, the emphasis is placed on prevention and elimination of pulpal infection. So the treatment objectives are that we have to either avoid or minimize the resultant inflammation. Any kind of inflammation should not take place. When osseous replacement of the root takes place, that is ankylosis, then steps are taken to slow it down. And in open apex cases, all the efforts are made to revascularize the pulp. If revascularization fails, then all the efforts are made to prevent or eliminate any toxins so that inflammation does not take place. So now let's see the emergency treatment at the accident site. So the best possible thing to do is replant the tooth if it is possible. It should be placed gently back into the socket. Or the second best thing which can be done is that we have to place it in an appropriate storage medium. So it usually requires some person who has the knowledge, who knows the protocol at the site of injury, and this information can also be passed on phone if somebody consults on phone. Most important factor, like I told, is the speed with which the tooth is replanted back. So the time has to be really less. It should always be less than 20 minutes to achieve a better prognosis. So management in the dental office. So the first visit usually is the emergency visit. So during this visit, we have to thoroughly examine. A thorough clinical examination has to be done. Diagnosis and treatment planning is to be done during this visit. We have to prepare the root and socket, replant it back, give a functional splint, and prescribe local and systemic antibiotics. Also, management of any soft tissues if they are injured, and medical and accident history is to be taken, and if required, injection tetanus toxoid should be prescribed. So preparation of the root and socket. The surface of the root should be rinsed with saline if it is visibly contaminated. It is always better to replant with minor debris rather than completely destroying the periodontal ligament cells, because we need to preserve the PDL cells because that helps in healing. Examine the alveolar socket and then rinse with saline to dislodge any kind of clot and check for any fracture. So there are a lot of factors. Like I told, the most important ones are the extraoral dry time and the storage medium in which it is kept. So based on that, we'll discuss the treatment plan for each one of them. So if the extraoral dry time is less than 60 minutes in a tooth which has a closed apex, or 15 to 120 minutes in wet non-physiologic media, then we should rinse the root of the debris which is there with saline. Revascularization might not be possible, it's usually not possible, but there are chances that the periodontal ligament will heal. we have to immediately change the non-physiologic media into a physiologic one, that is Hank's balance salt solution. This is considered to be the most preferable medium. Periodontal ligament healing would be expected if the dry time is less than or equal to 20 minutes. Emdogain is a material which is found to be very valuable in this dry period. Then comes the extraoral dry time of less than 60 minutes in an open apex tooth, that is the tooth with an open apex. All 15 minutes to 6 hours in physiologic media, or 15 to 120 minutes again in wet non-physiologic media, but here we are talking about the tooth with an open apex. So here we have to promote revascularization of the pulp. So for that, soak it in 1% doxycycline for 5 minutes, rinse off the debris and then replant. So that reduces the chances of any infection, that is microabscesses in the pulp, and significantly enhances the chances of revascularization of the pulp. This 1% doxycycline solution can be prepared by dissolving 50 mg doxycycline in 100 ml of saline. Then comes the extraoral dry time of more than 60 minutes and in a tooth with closed apex. So here we have to remove the periodontal ligament by placing citric acid for 3 to 5 minutes and then gently scrape it using a scaler. Because it's no more useful in healing, so much time has elapsed. Soak it in fluoride, usually APF or sodium fluoride is used, for 20 minutes and then cover the root with Emdogain and replant it back into the socket. Alendronate is also used as a substitute to fluoride. Endodontic treatment, that is root canal treatment, should be performed. It can be performed extraorally, but there is no major advantage of doing so. Extraoral dry time if it's more than 60 minutes in a tooth with open apex, that is for younger child of maybe age 9 to 10 years, 8 to 9 years. Here, even if we replant, the prognosis might not be that great. So there is still a lot of controversy going on. The International Association of Dental Trauma does not recommend replantation, but replantation can be done and endodontic treatment can be performed extraorally because it is way easier to achieve a apical seal extraorally when as far as the open apex is considered. So this is a short, table summarizing the main factors, that is the extraoral dry time, the condition of the apex, and also what plays role is the storage medium. So if it is 30 minutes and it's an open apex, then revascularization of the pulp and continued root development usually takes place. So there is no need for doing any root canal treatment. Then if it is 30 minutes but in a closed apex, your periodontal ligament healing is excellent. There is again no need for root canal treatment. If it is 30 to 60 minutes in an open apex tooth, then the chances of revascularization become very less. So we have to initiate apexification in the second appointment. Here the teeth are soaked in 1% doxycycline, like I told, prior to replantation, because that increases the chances of revascularization. This is an important question. It has been asked many times that why doxycycline is used. So that increases the chances of revascularization. Then if it is 30 to 60 minutes for a tooth with closed apex, so root canal treatment has to be initiated in the second visit, that is after 1 week. And again the same thing, we have to soak it in doxycycline. That enhances the chances of revascularization. If it is more than 60 minutes in an open apex tooth, then soaking is ineffective as all the cells might have died by that time. So here the main aim is just to make the root resistant to resorption. That is, the main aim now shifts to that there should not be any complication, and root canal treatment has to be done now. Then if it is more than 60 minutes for a closed apex tooth, here again soaking becomes ineffective, and main aim is to prevent external root resorption with any kind of complication. Root canal treatment has to be initiated in the second visit, and teeth should be soaked in citric acid for 5 minutes, followed by fluoride solution, and then another 5 minutes in doxycycline, after which they can be replanted. So splinting is done usually in the first visit, that is the emergency visit. So the kind of splint which is required is a semi-rigid splint. The reason being that physiologic tooth movement is required. So it is done for 1 week. That depends on the type of injury. For avulsion, splinting should always be done for 1 week. That is 7 to 10 days, not more than that. For different kind of injuries, the time is different. Like subluxation, 2 weeks of splinting is required. Then in cases of extrusion or intrusion, the time varies. So for X articulation, that is avulsed tooth, 1 week is enough. Then the splint should be flexible or semi-rigid to allow the physiologic movement of the teeth. And after splinting, radiograph is to be taken to verify the position of the tooth. And if avulsion occurs along with any kind of alveolar fracture, then splinting is done for 4 to 8 weeks, because that is associated with alveolar fracture now. After initiation of the root canal treatment, splint is usually removed. So a flexible wire, monofilament, such materials can be used as for splinting. The ideal requirements of splint are: the intraoral application should be easy to place, simple procedure, placement removal should be very easy, adequate fixation for stabilization period, and it should not cause any kind of additional trauma to the teeth, and it should allow physiological tooth mobility, so it has to be semi-rigid. It should not cause any interference with occlusion. It should be easy to clean, and it should not cause any damage to the gingival tissue. Aesthetically pleasing it should be, and endodontic treatment sensibility testing should be possible even if the splint is placed. So then comes the adjunctive therapy. According to the American Association of Endodontics, for patients who are not susceptible to tetracycline staining, doxycycline 4.4 mg per kg per day, that is twice a day, on day 1, followed by 2.2 to 4.4 mg per kg per day for 7 days at appropriate dose considering the patient's age and weight, should be prescribed. And also for patients who are susceptible to tetracycline staining, penicillin V 500 mg 4 times a day for 7 days or a child equivalent dose should be prescribed. Chlorhexidine rinses for 7 to 10 days are prescribed. During the second visit, that is 7 to 10 days, now the focus of the treatment, it shifts, and now it is on the prevention of any kind of pulpal inflammation. The course of antibiotics is usually completed by this time. Chlorhexidine rinses can be stopped now. After initiation of root canal treatment, splint is removed. So here the extraoral dry time, if it was less than 60 minutes in a closed apex, that is the first criteria which we read, then there are no chances exist that revascularization will take place. We have to do a root canal treatment, and in signs of resorption, like if we see that the root has started resorbing, then calcium hydroxide is to be placed, and the dressing has to be changed every 3 months for 6 to 24 months. The canal is obturated when we see a radiographically intact lamina dura. If the extraoral dry time was less than 60 minutes in an open apex too, here look for the signs of revascularization. At first, the signs of an infected pulp initiate apexification. So we have to initiate apexification now. Infection in pulp can be potentially harmful if there is cemental damage. This patient should be recalled every 3 to 4 weeks for sensitivity testing. If the extraoral dry time is more than 60 minutes in a closed apex, then these teeth are treated endodontically in the same way as those which are treated with an extraoral time of less than 60 minutes. So if the extraoral dry time is more than 60 minutes in an open apex during the second visit, which is after 1 week, If the tooth was replanted, then endodontic treatment, if it was not done during the emergency visit, then we have to do it now. We have to initiate the apexification. If the endodontic treatment was performed in the emergency visit, then second visit is just the recall visit for assessment of healing. So endodontic treatment, it consists of three stages. That is, one is pulpectomy, which is remove the entire pulp, and then an interim medication is usually given inside the root canal, and which is usually the calcium hydroxide. Obturation of the root canal is done using gadda parcha and root canal sealer. Okay, so pulpectomy is the entire pulp is removed and within 7 to 14 days of replantation, and we have to it's recommended to delay the initiation of endodontic treatment in teeth which have immature apices, that is open apex, and extra dry time of less than 1 hour, because there we have to promote revascularization. Interim medication, calcium hydroxide is placed minimum for 7 to 14 days. In long extraoral time, that is where the time elapsed was more than 60 minutes, or if there is any sign of resorption, calcium hydroxide is to be placed for prolonged periods of 6 to 24 months. Alternatives include Lidomex, which is a mixture of doxycycline. It inhibits dentinoclast, and calcitonin with osteoclast inhibiting property. So these are some of the alternatives which can be used, but the most commonly used medicament is calcium hydroxide. So the temporary restoration is given after the interim medication is placed inside the canal. This is just for the effective sealing of the coronal axis to prevent any kind of infection from the coronal side, and it's recommended to use ZOE or GIC for the same, zinc oxidation or glass ionomer cement. A depth of at least 4 mm is essential for effective seal. Obturation 2 weeks later, if replanted within 30 minutes, that is the extra dry time was less than 30 minutes, and endodontic treatment was initiated in the second visit 7 to 10 days after avulsion, and clinical radiography examination do not indicate any kind of pathosis or any kind of resorption, then we should obturate. And it is prolonged if replantation was delayed or endodontic treatment was initiated after more than 7 to 10 days after avulsion, and any kind of pathosis or active resorption is visible. Permanent restoration, the tooth should be restored at or soon after the time of obturation. Composite resin with addition of dentin bonding agent is recommended. These strengthen the tooth internally against any kind of fracture. Follow-up care is, if osseous replacement is identified, that is ankylosis occurring, then we have to revise a long-term treatment plan. If inflammatory root resorption is seen, a new attempt to disinfect the root canal is made, and the adjacent teeth are also tested time and again. The complications, we'll just have a quick look at the complications which might take place. So the most serious complication and the cause of tooth loss, that is which differs the prognosis or are the three type of external root resorptions which take place. One is surface resorption, then replacement resorption, inflammatory resorption. So these can be classified as non-invasive and invasive. Surface resorption is invasive, non-invasive type of resorption, and replacement resorption, which is usually also known in simple terms as ankylosis, and inflammatory resorption are the invasive types of resorption. So surface resorption is a self-limiting process, and here it is frequently found in replanted teeth. It occurs in areas of localized necrosis in the PDL. The microabscesses take place in the PDL, and extensive resorption is prevented by repair from the PDL and adjacent cementum. So it is a reversible kind of a resorption which takes place. Alternate, it's also called as root resorption associated with minor necrosis or necrosis associated root resorption. Then dentoalveolar ankylosis or replacement resorption. It is seen when the large areas of PDL are lost. That is, when the attachment apparatus is lost or damaged, then this ankylosis takes place. So healing now takes place from the alveolar side of the socket, and incomplete in people or patients where incomplete skeletal growth has taken place, it might result in infraocclusion as well. Undesirable healing, but still it is not pathological. And osteoclast cannot distinguish bone, dentin or cementum, so that's the reason why it takes place, and it could be diagnosed 4 to 6 weeks post replantation. Inflammatory root resorption, this is the one which is pathological. Here, radiolucent bowl-shaped resorptive defect is usually seen, can be easily identified in an IOPR. Infiltration of lymphocytes, all the inflammatory cells, plasma cells, granulation tissue can be seen. Toxins from infected necrotic pulp can pass through the dentinal tubules communicating with the periodontal ligament space, and that causes rapid destruction of the root. The storage media in order of preference, usually milk is used, that is low fat milk, cold milk is preferable. Saliva can be used in the either in the vestibule, but that is for recommended for adults, not for children. In physiologic saline or normal saline can be used. Water is also used if nothing is there available. Then there are commercially available media which are very good, cell culture media. Then Hank's balanced salt solution is the best possible or preferable medium. Wirespan, Dentosafe, these are some of the media which are used. Okay, then patient instructions. We have to instruct the patient to take soft diet for 2 weeks. Brush the teeth with soft toothbrush after every meal. Hand chlorhexidine mouth rinses are recommended 0.1% twice a day for 1 week. Regular follow-up is to be done. Okay, so this is how healing takes place in the periodontal ligament after reimplantation. After 3 days, separation line in the middle of the PDL, which is mediated by a blood clot, is seen. After 7 days, the attachment of the junctional epithelium reestablishes, the gingival collagen fibers are reunited, and the continuity of the severed periodontal ligament reestablishes with the connective tissue. After 1 month, the periodontal ligament, it appears completely normal, but connective tissue is yet not mature. And after 4 months, re-establishment of a functionally oriented periodontal ligament takes place. The follow-up procedure is very simple. We have to just check for these two things. One is splint removal. It should always be done after 1 week. Like I told, for avulsion, splinting is to be done only for 1 week. Okay, and C stands for clinical and radiographic examination, which is to be continuously done. So the patient has to be followed for a long period of time. Okay, after 1 week, splint removal and clinical radiographic examination, both for closed and open apex cases. And after 2 to 3 weeks, patient has to be recalled, clinical and radiographic examinations to be done. After 3 to 4 weeks, again after 6 to 8 weeks, again after 6 months, up to 5 years, the patient is to be followed up in such cases, because the prognosis is very uncertain and complications can result. So now we'll just quickly discuss few MCQs which I found might be at times a bit confusing. We'll start from the simpler ones. So this question, which medium of storage for avulsed tooth is best for prolonged extraoral period? Always if in the option HBSS is given, just go for it, because compared to any other media so far, uh, Hank's balanced salt solution is considered the best. There have been studies going on several natural products also these days, like aloe vera juice and egg and coconut water, other than distilled water, milk, saliva. So always the best preferable medium is Hank's balanced salt solution. This second question is the success of reimplantation procedures related to. So the options are vitality of the pulp, the extent of the soft tissue injuries, time lapse between tooth loss and replacement, media in which the tooth was stored after avulsion. See, always go for the time elapsed between the tooth loss and replacement. Media always comes second. Okay, the storage medium, although it matters, but it is not as important as the extraoral dry time. So the option might be extraoral dry time also. That is the answer. Then another question is, a child with an avulsed tooth half an hour back should carry the tooth to the dentist in. So these are all the options which are given here. Cold milk, normal saline wrapped in a wet handkerchief, buccal vestibule. So buccal vestibule is also preferable medium, but It is recommended only for adults who are conscious and not for children because they might swallow it. So cold milk, if the option would have been low fat milk, then you have to go for low fat milk. So this is another question. To store avulsed teeth, which kind of medium is shown to be suitable? So here, don't go for cold milk. You have to always answer low fat milk. So when both are given in the option, you have to say, you have to answer low fat milk. After avulsion of the tooth, 60 minutes have elapsed and it is kept in doxycycline for 5 minutes for the purpose of. So here the options given are revascularization to block calcium channels, to condition the cementum, or revitalization of the periodontal ligament. So the answer is revascularization. Actually, the most appropriate option would have been to make it resistant to resorption. See, doxycycline helps in revascularization, but if it is the tooth was brought to us either before 30 minutes or before 60 minutes, that is 30 to 60 minutes of time period, it helps in revascularization. But if it 60 minutes have already lapsed and then the tooth is brought to us, then it is to make it resistant to resorption so that any kind of complication does not take place. But that is not, since that is not given the option, you have to go for revascularization. Okay. Then two more questions. Uh, the chief cause of failure of replantation of the avulsed tooth, ankylosis. This is one of the common complication. Infection, external resorption, internal resorption. Okay, so these are all the complications which might take place, but the most common cause of failure of the treatment is external resorption because that is a pathological resorption, invasive pathological resorption. Then the last question which I'll discuss is the recommended time period for splinting of avulsed tooth. Simple. I have been emphasizing that it should always be 1 week, not more than that. Okay, for an avulsed anterior tooth. So these were some of the questions which I found might be important to discuss. Um, if there are any queries, you feel free to ask. I'll gladly, respond to any kind of queries related to this topic. Thank you so much for listening. All the very best for your exam. Thank you.